And that's a really interesting question, because you're absolutely right. Anil Patel and Reza Darya's paper was published in 2015, but it was published for a small group of people, who were interested in providing apneic oxygenation to patients undergoing laryngotracheal surgery. People who'd previously been managed with jet ventilation, a high pressure system, and suddenly Thrive offered us the chance to perform laryngotracheal surgery with a low pressure system, giving us less chance of barotrauma. And I think most ENT or head and neck anesthetists or anesthesiologists leapt at the opportunity to use a system which might have fewer complications than the sort of high pressure source ventilation systems we'd been using up until that point. Of course, the problem is that, and when an idea catches on, lots of people start using it. And so really the reason for producing an opinion piece now on questions you can ask to improve the safety of your apneic oxygenation techniques or your high flow nasal oxygen spontaneously ventilating techniques was to just make sure people were thinking about the right questions in their hospital environment so that they can use high flow nasal oxygen safely. And I suppose I should correct myself from my inadvertent use of acronyms. In the article itself, we talk about high flow nasal oxygen, HFNO SV, and HFNO AP. So high flow nasal oxygen spontaneously ventilating and high flow nasal oxygen apneic. They're different techniques for different times. But our desire to write an article just now is really about delivering patient safety and improving patient safety around high flow nasal oxygen techniques now that it's being more widely adopted. It may not change your practice, but we'd very much hope that using the questions we've provided, it will help you just make sure your practice is as safe as it possibly can be. High flow nasal oxygen seems incredible, and we could divide this podcast into two halves. The first half of which we'd spend discussing what's happening CO2 clearance, and we'll maybe deal with that in a second. But this is more for the clinical user of high flow nasal oxygen in the apneic setting, in the laryngotracheal surgical setting. And it's to make sure that the whole theatre team is aware of what's going on and aware of their role in making sure the patient is okay. Because whilst the low pressure setting of apneic oxygenation removes that risk of barotrauma, there are things that you need to do with apneic oxygenation to make sure the patient is safe. And probably the primary one of that is the ability to intervene and to oxygenate the patient by an alternative method if the patient starts to desaturate. And that can be quite a process. If a surgeon has done suspension laryngoscopy, the whole team needs to be ready to act quickly if the saturation starts to deteriorate and have a deliverable plan B. Oh dear, back to plans A and B, I apologize for that. But it's really important that the team have a deliverable plan B in their theatre environment, and so that they're aware of what they all need to do to keep the patient oxygenated should at any time apneic oxygenation start to fail. Well, of course there are. I think that there's a whole pile of mechanisms that we don't yet understand. There are a couple of papers, again, that Matthew Payton, Prof. Grice, the people starting to write about what mechanisms might be or could be, or what they think they might be, and then discovering that actually they're not those. But as I say, for us as anesthesiologists using high flow nasal oxygen for laryngotracheal surgery, our priority is patient safety. How can you use this apneic oxygenation safely and ensure it's appropriate in your practice? And I think the really important thing to go back to is it's all about having a plan. It's about making sure your team know what they're doing and what you're trying to achieve, and what they need to do should the patient start to desaturate. And at the end of the article, we wrote I think 8 or 9 questions, really designed to get people thinking about their own high flow nasal oxygen techniques in their theatre complexes. And we said there are patient factors, so are there any factors that may limit the safe apnea time for a patient, such as obesity? And That's another article in its own right. Does obesity limit the sleep apnea time? Well, up until John Cousins' work, we all thought it did. After John Cousins' work, well, if you can get patients with a BMI of over 40 apneically oxygenated for 18 minutes, clearly it works in the obese patient. But at the same time, if they're not sitting upright, if they're not optimally positioned, then maybe it's not so effective. It's a whole remit of work we've yet to work out. Certainly, some case reports and some case series have suggested that obesity limits your apneic oxygenation time. I'm not a clever physiological scientist. I'm not going to get involved in the arguments about CO2 clearance or anything else. But I think there's lots of work to be done here in improving things like a patient safety checklist. And the obvious thing to do here would be to do a Delphi exercise with experts around the world who use high-flow nasal oxygen and come up with a plan for a checklist that's reasonably universal and reasonably generic, or that can be easily adapted to people's practice, based on the idea that actually we need to look for patient factors, pathology factors, and team factors to make sure our patients benefit from high-flow nasal oxygen when they're apneic.